Today, we're diving into something that's pretty scary and surprisingly common, a collapsed lung. And we're going to look at how the very latest science is suggesting that sometimes, just sometimes, the absolute best thing to do is almost nothing at all.
You know, for decades, the playbook for a collapsed lung was pretty clear: immediate and often pretty invasive intervention. But brand new guidelines, fresh out of 2024 from Europe's top respiratory experts, are basically throwing that old playbook out the window. They're asking this really revolutionary question: what if, for a lot of patients, doing less is actually doing more?
Okay, so first things first, what exactly are we talking about? A spontaneous pneumothorax. Just think of your lung like a balloon. Now, that balloon is sitting inside a rigid box, which is your chest. If that balloon springs a tiny leak, air escapes into the chest cavity. That air has nowhere to go, so it starts squeezing the lung, and bam, it can't fully inflate. That's a collapsed lung. And the spontaneous part? That just means it happens out of the blue, with no injury.
Now, this is super important. Not all collapsed lungs are created equal. The new guidelines draw this really critical line in the sand between what's called primary spontaneous pneumothorax, or PSP, that happens to otherwise healthy people, and secondary, or SSP, which happens to people who already have a lung condition. And this distinction, it changes everything. It's the key to who might be a good fit for this new less is more approach.
So, let's walk through this. Imagine you're in the emergency room. You've just gotten the diagnosis. What happens in those next few minutes and hours is the first huge decision point. And it's right here that these new guidelines are making their biggest waves. Doctors have a whole toolbox of options, right? It's a spectrum, from just watching and waiting all the way up to major surgery. Traditionally, if you had a big collapse, it was almost an automatic trip to getting a chest drain put in. But these new guidelines are saying, hang on, let's pump the brakes. They're suggesting we should be starting way, way lower on that intervention ladder.
And here it is. This is the first absolute bombshell from the guidelines. For a patient who is stable, who has a primary collapsed lung, the recommendation is now to just observe them. And get this, even if the collapse looks huge on the X-ray, the size on the film is no longer the automatic trigger. The focus has totally shifted from the picture to the actual person and how they are doing.
So what if you do need something done? Well, here again, the guidelines make a really strong recommendation. Instead of jumping to a big chest tube that has to stay in for days, they say to start with needle aspiration. It's just a simple, small needle that draws the air out. It's way less invasive, and now it's officially the preferred first move.
This all sounds fantastic, right? Less invasive, simpler. But what does the evidence actually say? How do these different treatments really stack up when it comes to getting better? Let's take a look at the data.
And this is where it gets really, really interesting. Just look at the time spent in the hospital. The watch and wait approach, on average, patients are home in a single day. A single day. Now compare that to 4, almost 5 days for the more invasive procedures. It's incredible. Doing less literally gets you back to your life so much faster.
But, and this is a big but, here's the trade-off. Conservative care, that watch and wait approach, has a 9% chance of it happening again. Needle aspiration, that jumps up to 25%. But surgery, on the other end of the scale, drops that risk all the way down to just 6%. And this really gets to the heart of the dilemma for a patient. Do you want a faster recovery right now, or do you want a lower risk of going through this whole ordeal again?
So what happens when things don't go to plan? When the lung is just stubborn and it won't heal on its own? Sometimes that initial treatment isn't quite enough, and that air leak just keeps on going. This is where things can get a bit more complicated.
This is something called a persistent air leak, or POW, and it's pretty much exactly what it sounds like. That little hole in the lung just refuses to seal itself up. For patients who might not be good candidates for surgery, this can be a real challenge. So doctors have this really ingenious trick up their sleeve. It's called an autologous blood patch. It's a clever solution where they take a little bit of the patient's own blood and inject it into the space around the lung. The idea is that the blood forms a natural clot, creating a kind of patch over that stubborn leak, finally giving the lung a chance to heal up.
For pretty much anyone who's gone through this, the single biggest question on their mind is this going to happen again? I mean, of course it is, and preventing a recurrence is a huge, huge priority.
Because look at the numbers. For someone who's had a primary collapsed lung, there's about a 1 in 4 chance that it will happen again. 1 in 4. With odds that high, You can see why stopping it from recurring is a major focus of these new guidelines.
And that leads us to another really big shift in thinking. The guidelines now frame surgery as a proactive choice, not just a last resort. So if your number one goal is to make sure this never happens again, you can actually choose to have a preventative keyhole procedure, called VATS, right after your very first episode. The choice is yours.
You know, this also shows something really important about medicine. It's always evolving. For a lot of these advanced questions, like what's the absolute best surgical technique, or whether using suction on a chest drain helps, the guidelines are very honest. They say, look, the evidence just isn't clear enough yet. The jury is still out, which tells us there's still so much to learn.
So finally, what about life after you get out of the hospital? A collapsed lung isn't just some medical event that's over and done with. It can actually change how you think about your own body and some of the activities you do. And the guidelines give some pretty clear advice on this.
The evidence on this is just completely overwhelming. The single biggest risk factor by far is smoking. It dramatically increases your chances of having a first-time collapse, and it skyrockets the risk of it happening again. The guidelines really see this as a powerful, teachable moment, a serious wake-up call, and a critical chance to quit for good.
And what about those with a bit of an adventurous spirit? Well, there are some pretty specific rules. You need to wait at least a full week after your lung is confirmed to be 100% healed before you even think about getting on a plane. And scuba diving? Well, because of those extreme pressure changes, it should really be considered permanently off-limits, unless you've had that definitive surgical fix.
When you step back and look at the big picture, these new guidelines really represent a huge shift in medical thinking. We're moving away from a one-size-fits-all, do-something-aggressive approach. Instead, they empower doctors and patients to actually make decisions together, to weigh the pros and cons of every option. And really, it points to a future of more personalized medicine, where the best treatment isn't just about the illness, but about what truly matters to the patient.